learning about the ameloblastoma. We'll be covering the topic ameloblastoma under following headings. So this is our content. Coming to the introduction, ameloblastoma is a benign odontogenic tumor of the enamel organ. So ameloblasts are the cells which produce the enamel. So ameloblastoma is the benign odontogenic tumor. It is odontogenic tumor of the enamel organ type tissue which does not undergo differentiate to a point of enamel formation. So it is the second most common odontogenic neoplasia in the world and most common odontogenic neoplasia in the India. So coming to the origin, ameloblastic epithelium has been hypothesized to arise from the cells from the rest of enamel organ, cells of sheet of heart twigs or epithelial cell rest of malaces, epithelial boundary of the odontogenic cyst, particularly the dentigerous cyst, basal cells of the oral mucosa, heterotrophic epithelium from the other parts of the body may be pituitary. The histopathology goes like it resembles the normal odontogenic or enamel epithelium and ectomesenchyme. There are six subtypes histologically: follicular ameloblastoma, plexiform ameloblastoma, acanthomatous ameloblastoma, basal cell ameloblastoma, unicystic ameloblastoma, dysplastic ameloblastoma. So we will be covering these histopathological types of ameloblastoma in detail in our upcoming slides. So the mixture of the different patterns are often seen in the single lesion, and the classification is based on the predominant pattern present in it. So the WHO 2005 classification for the ameloblastoma includes four subtypes. First one is solid or multicystic, which is most common type. There might be unicystic. In unicystic, we have intraluminal or intramural. So third type is extraosseous ameloblastoma and dysplastic type of ameloblastoma. The malignant subtypes of the ameloblastoma are not included in the. We have Vickers and Corlin criteria for a lesion to be called as ameloblastoma histologically. They should have the tall and columnar cells, hyperchromatic nucleus, palisaded nuclei, reversal of the polarity of the nuclei, and subnuclear vacuole formation. So next, uh, coming to the follicular ameloblastoma, it is most readily recognizable and common type of the ameloblastoma histologically. So it consists of the islands of the epithelial cells with the central mark of polyhedral cells or loosely arranged angular cells resembling the stellate reticulum. So here we have the boundary of the tall columnar cells, that is nuclear is hyperchromatic in this, and there is reversal of polarity, and the central mass of the cell, that is stellate reticular formation, will be seen in the follicular form of the ameloblastoma, surrounded by the well organized single layer of the cuboidal or tall columnar cells with the nuclei placed at the opposite pole of the basement membrane resembling the preamyloblast. So this opposite pole, the nuclei placed at the opposite pole, is called reversal of the polarity. The peripheral cell layer tends to show the cytoplasmic vacuolization. Cystic formation is often seen in the center of the epithelial island due to the degeneration of the stellate reticulum-like cells. So coming to the plexiform ameloblastoma, the tumor epithelium is arranged in the form of network or trabeculae bound by the layer of the cuboidal or the columnar cells. Stellate reticulum-like areas are usually minimal. The cyst formation occurs but is usually due to the stromal degeneration rather than the cystic changes in the epithelium. The stroma consists of the loose vascular, sparsely cellular connective tissue. So here we can see the epithelial border of the cuboidal or columnar cells. Stellate reticulum-like cells will be there, but it is minimum as compared to the uh, filiform ameloblastoma. Coming to the next type, that is acanthomatous ameloblastoma. It resembles typically the follicular ameloblastoma except it shows extensive squamous metaplasia, sometimes with the keratin formation within the epithelial islands. So here in acanthomatous ameloblastoma we can see unique criteria, that is keratin formation, and sometimes there is extensive squamous metaplasia. Coming to the granular cell ameloblastoma, when the central stellate reticulum shows extensive granular cell transformation, that is of sheets of larger eosinophilic granular cells. If they are present, it is called the granular cell ameloblastoma. May be so extensive that the peripheral columnar cells may also be replaced, making the diagnosis difficult. Ultrastructurally, it is seen that granules consist of the pleomorphic, eosinophilic, and lysosomes like the organelles. So coming to the basal cell ameloblastoma, this variant shows predominant basaloid pattern, darkly stained cells with a minimal cytoplasm and little evidence of the palisading at periphery, resembling those seen in the basal cell carcinoma. So coming to the dysplastic ameloblastoma. It was first described in detail by the Eversole et al. In 1984, characterized by the extensive stromal collagenation and compressed small or irregular islands of the odontogenic epithelium. Cyst formation is common and ameloblast-like areas are present only in the small foci. So calcification in the fibrous stroma and occasional bone formation can also be seen here. Histochemical evaluation of the collagen shows that dense stroma is not a scar tissue but represent the active de novo synthesis of extracellular matrix protein. It typically presents radiographically as a mixed radiolucency and radioopacity, making the fibro-osseous lesion. In contrast to typical ameloblastoma, this variant frequents the maxilla and anterior region of the jaw. So usually ameloblastoma will be most commonly seen in the lower uh, mandibular posterior regions, but desmoplastic ameloblastoma has a frequency in the maxilla and the anterior region of the jaw. So coming to the unicystic ameloblastoma, this is considered as an in situ or superficially invasive form of the ameloblastoma. It consists of the single cyst lined by the ameloblastic epithelium. A 22-year and it usually occurs in and around age of the 22nd decade and clinically similar to the denturious cyst and is usually associated with an impacted tooth, usually third molars. They are usually seen in the younger patients with an average age of 22 years, diagnosis being generally involve the mandible. Histologically, the minimum criteria for diagnosing the lesion of the unicystic ameloblastoma is demonstration of the single cystic sac lined by the odontogenic epithelium, often seen only in the focal areas. Ackerman et al. Classified this entity into three histological groups, that is group 1, group 2 and group 3. Group 1 is considered as a luminal unicystic ameloblastoma. It is the tumor confined to the luminal surface of the cyst. Group 2 is intraluminal or plexiform unicystic ameloblastoma, that is nodal proliferation into the lumen without infiltration of the tumor cells into the connective tissue wall. Group 3 is mural unicystic ameloblastoma, that is invasive islands of the ameloblastous epithelium in the connective tissue wall not involving the entire epithelium. So this classification was given by Ackerman, and it was modified by the Philipson and Richard as subgroup 1, which is luminal unicystic ameloblastoma, subgroup 1 and 2, which involves both luminal and the intraluminal unicystic ameloblastoma. Subgroup 3 includes all three luminal, intraluminal, and intramural. The subgroup 4, that is 1 and 3, it includes luminal and intramural unicystic ameloblastoma. So, coming to in detail of all this unicystic ameloblastoma, coming to the luminal and unicystic ameloblastoma, cystic lesion lined by the epithelium, that is columnar differentiation and reverse polarization of the basal cell layer can be seen. The connective tissue is uniform, thin band-like area of hyalinization. So here it is not invaded into the connective tissue. The histological type is luminal type. Coming to the next, luminal and intraluminal unicystic ameloblastoma is the simple type but exhibits one or more nodules. No extension is seen into the surrounding connective tissue wall. So no extension seen into the surrounding connective tissue walls. Can produce an intraluminal plexiform pattern of odontogenic epithelium that lacks typical ameloblastous differentiation and is called as a unicystic plexiform ameloblastoma, as called by Gardner. It does not exhibit the histologic criteria for the ameloblastoma published by Vickers and Corlin. Not always associated with the unerupted teeth, it has low rate of recurrence following the enucleation and the curettage. Coming to the third type, that is luminal, intraluminal, and intramural unicystic ameloblastoma. The occurrence of intramural proliferation of the ameloblastoma along with the subgroup 1 and 2 features, that is luminal and the intraluminal features. Into the connective tissue, there is again intramural proliferation of the ameloblastoma. So coming to the luminal and intramural unicystic ameloblastoma, it exhibits a cyst with a luminal lining in combination with the intramural nodules of the SMA tissues. Intramural ameloblastoma tissues may be seen as an infiltration from the cyst lining or as a free islands of the follicular ameloblastoma. The clinical application scores like unicystic ameloblastomas are diagnosed as subgroups 1, 1.2, treated conservatively, that is enucleation. Subgroups 1, 2, 3 and 1, 3 showing the intramural growth treated radically, that is as a solid or multicystic ameloblastoma. Vigorous curettage of the bone is discouraged since it may impact the foci of the ameloblastoma more deeply into the bone. Chemical cauterization with the Cornell solution is also advocated for the subgroups 1 and 1.2. Subgroups 1, 2, 3 and 1, 3 in which the cystic wall is involved with the islands of the ameloblastoma tumor cells and there is possible penetration into the surrounding cancellous bone are thought to be associated with a high risk of recurrence requiring more aggressive surgical procedures. So coming to the peripheral ameloblastoma, it is present with a follicular or plexiform pattern as well as the acanthomatous pattern. In most cases, tumor is well separated from the overlying epithelium but may be confluent with the overlying mucosa. So other rare variants of the ameloblastoma may be clear cell variant, which may contain the clear PSA positive cells are localized in the stellate reticulum like areas. Um, Papilloserum keratoameloblastoma, it is the another rare variant, shows the occurrence of the areas of the ameloblastoma with keratinization, tumor islands with the papillophorus appearance along with the cystic areas resembling the odontogenic keratocystis. Coming to the third type, that is hybrid ameloblastoma, extremely unusual desmoplastic variant with the areas of the classical follicular and the flexiform variant. Some cases tumor cells with a granular transformation along with the areas of the follicular and flexiform ameloblastom, while some shows the basiloid changes. Coming to the hemangiomatous ameloblastoma, it is less common. Connective tissue stoma with the many blood-filled spaces or the large endothelial-lined capillaries. The theories for hematogenous ameloblastoma goes like hematomatous malformations, trauma, separate neoplasm, or the collagen tumors. The other rare variant is pituitary ameloblastoma. It has a neoplasm involving the central nervous system. It is common in the childhood and the adolescence. Origin: unobliterated portions of the fetal craniopharyngeal duct derived from the Rathke's pouch, and epithelial remnants of this duct are common on the adults. Peripheral or extraosseous ameloblastoma. It is uncommon, only 1 to 10% of all the ameloblastomas. It arises from the rest of dental lamina beneath the oral mucosa or from the basal epithelial cells of the surface epithelium. Histopathologically, same features as the intraosseous form of the tumor. So, metastatic ameloblastoma or ameloblastic carcinoma. Coming to the metastatic ameloblastoma, it is a well-differentiated benign, histologically similar to the solid or multicystic type at their primary site, but additional foci of the benign histology are identified in location remote from the primary and considered to be a metastasis. Coming to the ameloblastic carcinoma, an ameloblastic carcinoma, that is cytologic feature of the malignancy in the primary tumor in a recurrence or an metastatic deposit, shows the histopathological feature of the ameloblastoma both in a primary tumor and in the metastatic deposits. Aggressive lesion with the ill-defined margins and the cortical destruction. These are my reference. Thank you.